we discussed earlier, the differential response to MEK inhibitors in KRAS G12R compared to KRAS G12D and KRAS G12V relies partly on the inability of KRAS G12R to activate that wild type RAS due to the inability to inhibit NF1 and activate SOS1. So in other words, there's a weaker holistic MEK pathway in the case of KRAS G12R, that can actually be inhibited with MEK inhibitors. So KRAS G12R also does not have the ability to interact with the alpha subunit of P13K, utilizing that as an escape mechanism in a shunted growth pathway when MEK is inhibited. So like any other treatment in pancreatic ductal adenocarcinoma, the earlier these treatments are used, the more effective they will be rather than later in line.
And we do actually have a separate study as part of Dr. Kamgar's work with the KRAS G12R patients. This study is evaluating the role of MEK inhibitors, actually in combination with hydroxychloroquine and an autophagy inhibitor in the first or second line of treatment in patients with metastatic pancreatic ductal adenocarcinoma who have the KRAS G12R alteration. So in that study, we found that treatment was associated with progression-free survival of about 7 months, with continued disease control that extended to 22 months in some of our patients.
Yeah, a good question. So I would say what we saw in a lot of our patients in different lines of treatment on MEK inhibitor is disease control, meaning that it seems to be specifically in earlier line of treatment, a good medication to stabilize the disease. While we saw progression, like partial responses or such, those were not really abundant. So what I can tell you is that what we can achieve with MEK inhibitor alone or in combination with other treatments is mostly stabilizing the cancer. This is opposed to at least early results from KRAS inhibitors or RAS inhibitors, that they can also provide some response in terms of shrinkage in the size of the tumor. The challenge with those approaches, similarly with ours, is the duration of response. How long would the tumor respond? So I think in the era of hopefully development of more effective RAS inhibitors, the role of MEK inhibitor will be probably helping those in achieving a more deeper and a more durable response, as well as like potentially other combination if we can understand other drivers other than the MAP kinase pathway. I would say, however, we have to be careful with the combinations. Some of these drugs have overlapping toxicities. So skin rash, diarrhea, those are things that can be similarly seen in some of the drugs, including RAS inhibitors and MEK inhibitors. So I would think if a MEK inhibitor is used, probably it can be used with more specific KRAS inhibitors, such as a KRAS G12R inhibitors. Those potentially don't cause much side effects. And then you can add some like MEK inhibitor to that treatment in KRAS G12R altered patient to be able to achieve a more durable response.
The MEK inhibitor therapy, as we've kind of mentioned, we've seen modest disease control in patients who have metastatic disease and with the G12R alteration, and frequently used in the late line setting. And in this particular patient population in these studies, we found that the MEK inhibitors have had acceptable safety profiles. Again, our median progression-free survival of 4.9 is 4.9 months is favorable compared to typical like benchmark progression-free survival in second line and beyond, which we would think would be 2 to 3 months with standard chemotherapy. In so like I said, our 8 patients with the G12R mutation that we retrospectively reviewed, the most common side effect that I saw with the MEK inhibitors reported was rash. It was, but the rash was never grounds for treatment discontinuation. So I think from that standpoint, it's reassuring. This rash was typically an acneiform rash that presented in the face, neck, and shoulders.
Yeah, and other toxicities, each toxicity of different regimens is very different, very variable. Cytopenia, nausea, vomiting, diarrhea, hair loss, and neuropathy are all very common side effects seen with the conventional chemotherapy in pancreatic ductal adenocarcinoma, but it does depend on the type of combination therapy, and therefore the side effects can kind of differ. CDK4 and 6 inhibitors can cause neutropenia. EGFR inhibitors can cause skin rash and diarrhea, and combinations can cause deranged LFTs in a subset of patients. Toxicities overall, though, are mostly low grade and manageable with adequate support measures and dose modifications, and aren't necessarily reasons to stop the therapies.